Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by phone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Megan Rossiter, Improvement Lead at CFHI. Please go ahead.
Wonderful, thank you. Hello and welcome to today's on-call webinar entitled Shifting Care from Hospital to Home, the final webinar to a two-part webinar series where we've been looking at shifting models of care to more appropriate patient-centered care for chronic diseases with a focus on CFHI's inspired approaches to COPD Quality Improvement Collaborative. I'm Megan Rossiter, Improvement Lead here at CFHI, and I'm pleased to be your co-host today. I'm joined by my co-host and Senior Director, Jen Verma, who really shaped and led the Inspire Collaborative here at CFHI. We are pleased to have more than 150 registrants for this session and two-part series, and are glad all of you could join us live today as we conclude this series. As I introduce our guest speakers, I'd ask that you please take a moment to introduce yourself in the chat box that you see on your screen, as well as let us know how many people are attending from your location using the poll that you see on your screen. Please enter the number, including yourself. So joining us today to share in their inspired work, we have team members from the Centre Intégré de Services de Santé et de Services Sociaux of the Montérégie-Est region, including Jocelyn Trudel, respiratory therapist, Melanie Roussel, Director of Social and Multidisciplinary Services, and unfortunately Christelle Pelbois was unable to join us live today, but we're thrilled to be joined by Sonia Santel, who joins the team today as a Regional Healthcare Affairs Manager from Boehringer Ingelheim. Sonia has played an integrative supportive role in the team's inspired work through the collaborative. And from the Ottawa Hospital, we're joined today by Wendy Laframboise, who is a nurse practitioner and lead of their Inspired program. Finally, I'd like to mention we are also joined on the line by Dr. Graham Rocker, Professor of Medicine at Dalhousie University in Halifax and the Medical Director of the original Inspired program at the QE2 in Halifax. He's also on the line with us today. We also have our producers, Sheena Powell and Kelly Ripley, operating behind the scenes in Ottawa, and I'd like to welcome all of you. We are pleased to provide simultaneous interpretation for our on-call webinars. This may result in a few quick pauses in the dialogue today. We invite you to participate in the chat box today in either official language. So before we dive into today's webinar, we'd like to get a sense of who's joining us. Please take a moment to answer the poll you'll see on your screen to indicate your role. If there is more than one person attending from your location, please select the option that is most appropriate for each of you. To get started today, I'd like to first provide a quick recap of our series objectives, that is, sharing some of our learnings and results as they relate to appropriate care for chronic disease. For those of you who participated in Part 1, you'll recall there are 3 key objectives we highlighted for this two-part series, which includes discussing the importance of shifting care from hospital to home and ensuring that care is delivered in the right place at the right time, how home and community-based approaches to COPD care can improve efficiency, coordination, and patient and family-centeredness, lessons and the Inspire Collaborative, and CFHI's plans for further spread and scale. More particularly today, we're going to build off of Part 1, continuing the discussion that relates directly to approaches for shifting COPD care from hospital to home. We'll recap some of the impressive results that have come out of CFHI's inspired approaches to COPD collaborative and quickly move into hearing directly from 2 additional teams that participate in this collaborative, this time from Quebec and the Ottawa region, honing in on some of their strategies for success in delivering truly patient-centered COPD care. And finally, bringing Dr. Rocker into the conversation, we'll share some strategies for improving efficiency, coordination, and patient and family-centeredness for patients living with COPD and their families. We know that currently today, our system is facing increasing constraints due to an influx in inappropriate hospitalizations. It's clear that people are receiving the wrong care in the wrong place, which is harming our healthcare system and failing to meet the needs of patients and their families. We know that to overcome these deficiencies requires a system overhaul, that is, system transformation, driving change that builds in proactive care to keep people as healthy as possible rather than our usual reactive care that responds to people once they are sick, as reported by Dr. Edward Wagner and his colleagues at the McCall Institute. So again, why are we focusing on COPD? Although less than 5% of Canadians live with chronic obstructive pulmonary disease, COPD is the #1 reason for hospitalizations in Canada, accounting for the largest number of return visits to the emergency departments. COPD also generates the highest volume of hospital readmissions. Many patients with advanced COPD resort to episodic or emergency department care to manage escalation of symptoms or acute exacerbations, which is costly to our health system and the patient's health. Building off the impressive model that Dr. Rocker and colleagues built at the QE2 hospital in Halifax, CFHI worked collaboratively with the team to spread this evidence-based model nationally via Quality Improvement Collaborative. The Inspired Approaches to COPD Care Collaborative was made possible through support and funding from CFHI and Boehringer Ingelheim Canada Limited. CFHI supported through the 12-month collaborative a total of 19 teams, at least one team in each of the 10 provinces. So that looks like 4 in Western Canada, 7 in Ontario, 4 from the Quebec region, and 4 in Atlantic Canada. Over 12 months from October 2014 to October 2015, CFHI delivered and supported more than 25 team webinars, an in-person workshop, and 4 regional roundtables to discuss sustainability of this work. We provided funding and improvement tools, one-on-one team coaching with experts in the field, and cross-team learning. I'll now turn it over to Jen Verma, who will walk us through a recap on some of the impressive results and outcomes from this work. Jen, over to you.
Thanks so much, Megan. Really appreciate it. Just want to give a cue to our colleagues from Montérégie-Est or Pied-de-Sorel. If you could actually dial in to the French line, you'll look in the chat box. We're actually going to provide the dial-in information. Just want to make sure you have an opportunity to dial into the phone because I'm going to be coming to you shortly. So I'll give you a quick reminder if I don't hear from you. And if you're having any difficulties dialing into the phone line, just communicate with us in the chat box and we can facilitate your coming in on the phone. So Inspired, as Megan's been talking about, really exemplifies that shift of appropriate care from hospital to home. We're so reliant on hospital-based care, and Inspired shows us that you really can provide a great deal of necessary care in the comfort of patients' own homes with their families present. The core interventions that make up this model, from the optimization of guidelines and medications, care that addresses continuity across the continuum, proactive care including self-management support, individualized follow-up in the home, liaising with community services, and evaluating and monitoring for quality assurance really make this a comprehensive model of care for people living with advanced COPD, but we believe it also has application for other diseases that are amenable to keeping people out of hospital like congestive heart failure. And as we know, many of the very people who live with advanced COPD also have other chronic conditions. So across the 19 teams, we've learned a lot from them, and this gives a little bit of a summary. We've had more than 1,000 patients enrolled. We've seen an 80% drop in hospitalizations, and those have tapered to closer to 40 to 50% in the 6 to 12 months post-Inspired. Teams have reported optimized care, so they've enhanced the spirometry diagnosis, which is so critical. They've developed action plans, offered self-management support and psychosocial support, advanced care planning, and coordinated community partnerships with allied health. Families are telling us that they feel better supported over that hospital-to-home transition. They have the information they need to manage at home with their loved ones. And patients are also reporting increased self-confidence, better symptom management, a return to daily activities. And we've heard that through multiple sources, like the Lung Information Needs Questionnaire, the COPD Assessment Tool, the Care Transitions Measure, and so forth. When it comes to the return on investment, and this has been really critical for communicating to policymakers in particular and hospital administrators about the importance of delivering a program like Inspired. So we did an analysis that found that of the 800,000, and that's probably a conservative estimate, of people living with COPD across the country, that you would need to reach less than 1%, the less than 1% that lives with advanced to severe COPD. So that might amount to around 14,000 Canadians. If we were to reach the people who would stand to benefit from Inspired, we would be able to prevent something in the order of, almost 70,000 emergency department visits, 44,000 hospitalizations, and 400,000 bed days. That equates to about $688 million in the first 5 years of rolling this program out in reduced hospital-based costs. So all told, every dollar invested in Inspired really saves you 21, and you're going to want to bankroll that all the way that you can. It makes a lot of sense, not just from a health standpoint, but from a per capita cost standpoint as well. So I'm going to actually turn it over to our assist team if we have them online, which I don't think we yet do. So I think I'm just going to pause for a minute and just see if I can assist our operators in getting them online. Okay, we are good. So we're actually going to turn over to our Monterey S team, and I believe we have Sonia on the line.
Yes, hello. So on behalf of the Pierre de Sorel team, here is our presentation, the results that we've achieved so far. And I will be asking Jocelyne, who is our respiratory therapist, to take over. And could we move the slide forward, please? So here is an overview of what we decided to do for Inspired. We wanted to work from diagnosis to end of life. At Pierre de Sorel, we adjusted the program so we could meet the needs of our patients by providing a continuum of services. In other words, start from screening or diagnostic to the end of life care. To provide early screening, we work at the CLSC level, primary care level. All patients are seen by family doctors, specialty care doctors, or nurse practitioners who generally are in family medical groups. Then we move to action plan. We teach the action plan, and the other references are also provided at the front line. As the patient is referred to specialty services, nurse practitioners, and pharmacists are also referring patients more and more. Pharmacists within the community are involved in supporting and managing the action plan. All action plans for patients are transmitted to the pharmacist so that the pharmacist may also support managing decision-making regarding these action plans. The next step is preventing readmissions. We start following up on patients within hospital, and we can also involve primary care, either through home care or COPD clinics. We do hope that all patients that have been admitted are followed up on within 2 to 5 days of their hospitalization through a telephone call, even if they're known to the COPD clinic or they are newly diagnosed patients or pre-diagnosed patients, so that we can prevent any exacerbation. And the fourth axis is the action plan to manage breathlessness. This is generally managed by home care and palliative care. Next slide, please. And Mélanie Rousseau will be introducing us to this slide. In Quebec in 2015, a new legislation was adopted that changed the health system as well as social services within Quebec. This has overhauled the system and meant a lot of change for the stakeholders and management team of this project. Due to a lack of resources, we had to make difficult choices and stop using some standardized tools. However, the COPD program within Pierre de Sorel remains very popular. Currently, we're working on implementing the third axis, preventing readmissions, and we are implementing a role for respiratory therapists, and we also intend on sharing results with the new leadership of our new merged institution. Next slide, please. Christelle Pellebois should have been here, but unfortunately, she is not well today, so I'll be showing you these results on her behalf. When you look at the results, you need to take into account that we created 3 cohorts. The first cohort is a cohort of patients that are enrolled in the COPD program and that have an action plan. When we looked at the stats, this means 101 patients. The second cohort is a COPD clinic program through Jocelyn, but they don't necessarily have an action plan. So they represent 314 patients, including the 101 patients I just explained. And we also have a third cohort of patients that are not at all enrolled in the program. We compared the COPD cohort with or without action plan to itself. So we have a measure for 2013-14 and another measure for 2015-16. By looking at the statistics, it's very important to understand that this is a disease that evolves over time and that all patients are not enrolled on day 1. In fact, it's quite the reverse. More patients are enrolled recently in the patient than those that were enrolled when the program was first implemented. We compared both cohorts versus the cohort of patients that are not enrolled at all in the COPD program. Next slide, please. Jocelyn will introduce us to the COPD program use to date. We've had early diagnostics. 505 spirometric tests were done and 113 were follow-up tests. We now have 122 patients with an action plan that leave the COPD clinic with an action plan. And in the past, there were no home care tools to create action plans. So we now have implemented a new process. The forms are now used by home care as well. So out of 98 patients in COPD home care, 35 now have an action plan. Next slide, please. This slide is very busy, we apologize, but it's quite logical if you look at it closely. In the first column, what you see is the cohort of patients that have COPD but don't have access to the program. And we compared the years 2015-16 to the years 2013-14. And in the second part of the table, to the right, you can see the cohort of patients that are enrolled in the COPD program. And in this case, we have users that had or did not have an action plan. So what you can see is that for ER trips for COPD, there was an increase of 19% for the cohort that was not enrolled in the COPD program. However, there was a growth of 97% for our cohort of patients. What the statistics did not allow us to verify is if this is ambulatory visits to the ER or if it's gurney time. We're trying to refine our statistics to get an answer to that question. The other thing we looked at were hospitalizations for COPD. So within the cohort that does not have access to the COPD program, there was an increase of 104% of admissions compared to 0% for our cohort of patients that were enrolled in the COPD program. As far as the average length of stay, there was an increase of 4% for the clients that did not have access to the program versus a reduction in 9% for our patients. And as far as readmissions go, the 30-day readmission rate, I'd like to remind you that the fourth component of our project, which deals with readmissions, is not quite implemented, but we still have interesting results. Within the general population, there was an increase of 108% of readmissions versus only 50% for our client base enrolled in the program. Next slide, please. What you have here is the same idea. Our COPD cohort without an action plan, as compared to, when I say without an action plan, it means outside of the COPD program as well, versus the patients that are enrolled in the program and have an action plan. Now, as far as ER visits go, we had an increase of 29% for patients that were outside the program and don't have an action plan versus an 80% growth for our patients who have an action plan. For admissions, we have an increase of 103% versus 35% in our cohort. As far as the average length of stay goes, we went from an increase of 4% to a reduction of 35% for our cohort that had an action plan. And finally, as far as readmissions go, there was a growth of 114% within the general population and 0% in our cohort. So no increase for our patients enrolled in our program with an action plan. So once again, the statistics do not allow us at this time to see what the results are to the end of the year. There's a bit of lag time before we can get the data. And another thing we're working on is to look at the general COPD population. What was the impact of our program over time on this general COPD population? Once again, the statistics were not available to us at this time, but we're very curious to see what the impact the clinic will have had. Slide, please. Madame Rousseau will be presenting this slide. We are now then implementing the readmission prevention structure by including the lead respiratory therapist within the hospital setting. We're also assessing the usefulness of performing a qualitative evaluation program through 2 questionnaires. The first questionnaire will be filled out by users, by patients, and will be able to identify their understanding of the disease, their capacity to understand symptoms and change of their disease, their capacity to intervene when there are symptoms, and their perception of their health, and their understanding of the program. The second questionnaire will be filled out by frontline physicians that were part of the project in order to understand their appreciation of the program, the effect on patients, and the effect on follow-up of these patients. We will be sharing this information with the stakeholders and with management of our CISSS Montérégie Est. And I would quote Albert Einstein in closing, not everything that counts can be counted, and not everything that can be counted counts. And that's all for us.
Well done. Thank you so much to Jocelyn, Melanie, and Sonia. Those are very impressive results. Grateful that you were able to share those in such great detail today, as well as some of your plans for upcoming evaluation, qualitative evaluation. I think that's so critical. I'll just note for our audience that we do have some time now for Q&A. So if you do have any questions that you'd like to share in the chat box or comments as well, feel free to do that. Megan Rossiter has queued you up for that as well. I do have a question. I'm curious to know, so the original Inspired initiative, given its focus on patients living with advanced COPD, of course many would consider that patient population palliative. So I'm curious to what extent you have considered or would consider looking into advanced care planning or palliative care components of the work that you're doing with your patient population.
Patients that are not mobile are already handled by home care. So we already have that access. We have patients then that are cared for by home care.
Thank you, and I appreciate that you have upcoming the opportunities you mentioned to undertake qualitative evaluation of patients and physicians as well who've been involved in the initiative. But just out of curiosity, are you able to share any informal qualitative feedback that you've heard from patients and families across the two cohorts?
I'll let Jocelyne answer, who is the ideal person to answer that question. Jocelyne, yes, we have had a lot of wins. What we're measuring today are the admissions and discharges from hospital, but there are a lot of other things we can't quite measure, such as changes in lifestyle habits. In the clinic, we have group meetings involving 10 people, and all patients that agree to be part of those meetings have meetings with a dietitian, with a respiratory therapist that provides an exercise program that shows how to breathe properly, how to take their medication properly. So all of these people probably improved their lifestyle habits. They probably go to the physician quickly because many of these people do not have an action plan and don't act quickly when they have a symptom. So these are things that aren't measured. And yes, some patients have been admitted to hospital many times and thought they would never be able to do X, Y, or Z, and have begun doing those things once again. Many of them have mentioned those things. For example, a patient that was admitted 4 times in 2 months came to the clinic. We saw him with the following 10 days of his admission. We looked at his medication. We taught him how to exercise. We taught him how to take his medication. And with an action plan, this person has not yet been to the doctor in a year and a half. We've used his action plan twice in 1 year, and he's never been back. And he has begun exercising more because his goal was to be able to ride his motorcycle. And after a few months, he was able to ride his motorcycle again. So that's an example that we love quoting as healthcare professionals because it's near and dear to our hearts.
Thank you so much, Jessalyn. I have a few questions in here from Dr. Graham Rocker, who is actively listening in and contributing via the chat. So I'll pose actually the 2 questions together, along with he's added a little bit of commentary as well. His first question was about particularly the inspired cohort. He's wondering about the denominators in each of the time frames presented, meaning for all of those calculations, were those taken with 101 patients included in each of those 2 time frames? So that's his first question about the full cohort or denominator involved in those calculations. And the second question, he's curious as to why patients went to the emergency department and wondering if it would be to check on whether they would initiate the action plan. And he says further to that, while the admission data and length of stay is encouraging, the appearance of increasing, not decreasing emergency department visits needs a bit more explanation.
So to answer the first question, we were talking about the 101 patients. We compared the 101 patients to themselves. So the 2 time frames were 2013-14 and 2015-16. And we measured, in fact, what we have to recall is that the clinic was implemented on April 16th, 2015. But of course, not all 101 patients had an action plan as of April 16th, 2015. In fact, very few patients had an action plan on the day the clinic was launched. And it's for that reason that we decided to continue to compile statistics and to investigate further. And what we will do is match up patients who are in our cohort of 101 patients, and we will match 101 other equivalent patients to them in order to have a better comparison. And we will also compare them over time during the length of time that they're in the program. So the next series of statistics should be more informative. The second question was what can explain the increase in ED visits? I would admit that we were surprised by that data ourselves. But once again, you have to remember that Mr. X, a patient who may have begun the program on December 15th, 2015, well, that patient may have made emergency visits in May, June, July, and the statistics were still compiled as though this is a patient in our cohort, in the COPD cohort. So it could explain this increase, and that's why we are continuing to collect data and to investigate further. One of the theories that was proposed is that sometimes a respiratory therapist identifies patients that should go to the emergency department for a very good reason. And obviously, we don't expect that there be no emergency department visits in our statistics. But like you, we were surprised and tried to find explanations to this data. Another thing is that COPD patients tend to be very anxious. They're used to going to emergency departments and do so for years. So when they go to a hospital, they get x-rays, blood tests, and once we tell them in a clinic, you have an action plan, you don't need to go, it's very difficult to change their habits in terms of healthcare consumption, if you will.
Very helpful. Thank you so much. I appreciate that. Graham's added a little bit more thought on this, and I think what we'll do is we'll turn to Wendy at the Ottawa Hospital. But Graham, I think once Wendy's presented, maybe in that next Q&A we can come back, and I'd love to have you provide a bit more perspective on what your recommendation is to the Pierre de Sorel team in terms of that comparative data. For now, I want to welcome Wendy Laframboise, and I'm grateful for hearing the Ottawa Hospital's experience on today's call as well. Wendy.
Great. Thank you very much, Jen. So we'll move to the COPD Outreach Program at the Ottawa Hospital. So at the Ottawa Hospital, not unlike many other healthcare organizations, we have a high rate of 30-day readmissions for patients with moderate to severe COPD. And working in a hospital in Ontario, we acknowledge the need to implement improvement strategies derived from the Quality-Based Procedures Clinical Handbook for COPD from Health Quality Ontario and the Ministry of Long-Term Care. So to provide just a very brief background, our team consists of in-kind support from a respirologist, a clinical manager, a research associate, as well as resource-allocated full-time nurse practitioner and certified respiratory educator, which is myself. And I also have help 2 days a week from a registered nurse who is also a certified respiratory educator. So because our expertise is in pulmonary rehab, we adopted Dr. Rocker's Inspired program to a program that would improve referrals to both hospital and community pulmonary rehab programs in our region. And so how this is done, we receive referrals from medicine, family medicine, and respirology services from both the general and civic campus who are admitted with a COPD exacerbation. We meet with patients in hospital, enroll them into the program, and make recommendations to the inpatient team as required, for example, pulmonary function tests, optimization of medications, or community support. We complete follow-up phone calls 24 to 48 hours post-discharge at 1 month, at 3 months, and again at 12 months. Patients also have access to a phone line. They can call us from between 8 and 4 Monday to Friday. We complete home visits within 1 to 2 weeks post-discharge. And during the home visit, patients receive a COPD action plan, including education, inhaler techniques, smoking cessation counseling. And as appropriate, we facilitate a referral to the most appropriate pulmonary rehab program for the patient in our region. And we will also facilitate a referral for home support or palliative care as required. So how we accomplish this? Through coordination of care from hospital to home. So this includes coordinating with inpatient staff and community programs to ensure patients have the appropriate resources in place before leaving hospital or shortly after returning home. All of our encounters are recorded in the patient's electronic health record and faxed to the appropriate care provider. So we collaborate with lung health experts in the community and continue to deliver education to community care access center nurses, community health centers, family health teams, as well as the eMERGE department as far as what resources are available. So additionally, we receive calls from the ED, CCC, community health centers, and primary care, and provide answers and resources to them as required. So our program is implemented on respirology, medicine, and family medicine inpatient units at the Ottawa Hospital. To date, we have approximately 165, 170 patients enrolled into the program. We've improved access to hospital and community pulmonary rehab education programs. And if we look at the Canadian Thoracic Society 2015 guidelines, or their latest report, I think it indicates about 0.4% of patients in Canada with COPD have access to pulmonary rehab. We've actually, about 40% of our patients have been referred to pulmonary rehab programs. So there's also improved awareness of lung health resources throughout the region. Prior to this program, I found it difficult, for somebody working in pulmonary rehab, I found it very difficult to find resources. So I belong to what's called the Lung Health Network in the Champlain region, which is essentially a consortium of individuals invested in lung health in our region. So we developed an online toolkit which houses all lung health resources in one place on the Champlain Health website. Additionally, we've met with our local health integration network, the local funding body in our region, to discuss the value of our program and shared some early results. And essentially that meeting led to them asking us to submit a health system improvement plan. So we were awarded one-time funding for a program which is essentially bought us time to reallocate resources to secure permanent funding for the program. And as far as spread, again, belonging to the Lung Health Network, discussing our results quarterly with these individuals, the Cornwall Seaway Valley Community Health Center and Cornwall Community Hospital have adapted their model, having nurse practitioners go out into the community, essentially caring for COPD patients in their homes. So we continue to share knowledge, and we serve as almost a hub of information for community and acute care patients. We frequently receive calls from primary care and other healthcare facilities, residents in ICU, ED, surgery, for example. For most of these places, a lot of these places are looking to refer patients to us. Unfortunately, we're not able to accommodate, but we do provide resources for these individuals. So our research associate recently pulled some data from our first cohort of patients in the first 12 months. And we learned 62% of our patients were categorized as moderate to severe, and that's according to the GOLD criteria. 84% of these patients had received a flu shot, 52% had received pneumococcal vaccine, and 24% of the remaining patients appeared unaware of whether they had received this vaccine. 67% of our patients have actually had quit smoking prior to being enrolled in the program. I was actually quite surprised with that number. I didn't think that many people had quit smoking, but I guess it goes to show you the severity of breathlessness in the patients that we actually do see. So our results slide, and just to, I apologize, it's quite detailed. So the left side of the slide explains a cohort of patients with an N of 80 over a period of 12 months. So we've reduced the 30-day readmission rate for this patient population rate by 50%, reduced the 30-day ED revisit rate by 62.5%, and reduced inpatient length of stay by about 24.6%. We really believe the factors contributing to these positive results include recommendations to the inpatient team, clarification of medications in hospital, in home, with pharmacy, with primary care providers, coordination of care, as well as recommendation to patient for early assessment and treatment. And this often happens during our post-discharge follow-up phone calls. So if we look at the costs associated, and this is on the right-hand side of the slide, now I have down there pre-enrollment N46, post-enrollment N13. So in a 6-month period, 46 patients met the 6-month time frame. So 46 patients pre-enrollment. In the first 6 months for ED, pre-enrollment was about $6,800 and post-enrollment about $4,828. The most significant cost avoidance was in the readmission data. So of these 46 patients, 13 patients post-enrollment had hospital encounters. And what that equates is pre-enrollment. So pre-enrollment in the admission cost was about $510,000 and post-enrollment about $36,000. These costs were all derived from nursing hours, labs, diagnostic imaging, RT support, pharmacy, and allied health. And if we look at kind of total cost avoidance, pre-enrollment versus post-enrollment, $516,000 pre-enrollment and $41,000 post-enrollment. So just to update you, currently we're collaborating with respirologists to develop a COPD care model, which will include COPD outreach and referral to community programs. The first draft has been developed and should be implemented on the respirology unit any day now. Additionally, we're part of a study team, so we submitted a grant application to the Ottawa Hospital Academic Medical Organization to develop and evaluate a care model, which we believe will improve patient engagement and health confidence, leading to improved health service outcomes. Capacity building, the units are looking at providing more education to their nurses as becoming certified respiratory educators. We've also been collaborating with our nursing professional practice department to develop an education tool for nurses to teach patients on the inpatient units more about COPD, as well as the nursing professional practice department has approached us on feedback around a caregiver support grant. They want to develop a model for the hospital and want to use our patients to pilot the model. Next steps include focus on improved access to post-acute care, so to implement the pathway, to explore the opportunity to enroll patients from the ED, to streamline more referrals from the ED to community programs, to explore opportunities to develop, again, this, if we get the grant to develop the model, potentially the chief of quality is looking, can this model be adapted to all other chronic diseases as well, and explore telemedicine opportunities, which will allow us to reach more patients. So I think part of lessons learned shifting from hospital to home was best described with one of my visits with a patient. So she was a retired nurse, visited her home a few weeks ago, and she's noticed a real shift in the culture in healthcare delivery today. She identified the need for, as well as the value of patient-centered care. She noted how healthcare providers took the time in hospitals to explain everything to her, asked her permission, and involved her in healthcare decisions. She appreciated communication between her, the inpatient physicians, and the COPD Outreach team, and this took place around her bedside, knowing that her transition home would be safe and seamless. Additionally, she values the ongoing communication that will take place with our team and her primary care provider. And finally, she endorses that she has less anxiety about her newly diagnosed COPD, as she has a resource to call with any COPD-related questions. And in closing, I'd just like to say that the implementation, before this program, there was no COPD program at the hospital whatsoever. It's been almost a snowball effect of support and interest from both hospital and community stakeholders in our region and across Canada. I believe we all want the best for our patients, and with the fiscal constraints, we need to be more creative in the way we deliver care. Working together and drawing on the expertise of one another is the first step in breaking down these silos, creating a more effective and efficient system, and ultimately providing our patients with the best care possible. Thank you.
Thank you, Wendy and Ottawa Hospital team. Tremendous, again, results. Fantastic. Thank you so much for sharing, too, your next steps. I think that's really exciting. I want to encourage folks who are on the line, if you have questions for Wendy or comments that you'd like to make, of course, feel free to add those in the chat box. Graham, I am going to come to you shortly because I think hearing your take on some of the information that you shared earlier for Pierre de Sorel would be helpful, but I agree. Graham says, wow, Wendy. One question I have for you, and you actually started to address it, was we've had some thinking that what works well for people with advanced COPD could very well work well for other people with chronic conditions. And so there's movement at Ottawa Hospital, as you've said, to give thought to what you can extrapolate from this experience with COPD to develop other chronic disease management models that maybe facilitate people in going from hospital to home. Just curious if in your patients that you're working with who do have advanced COPD, presumably they do have other chronic conditions. I'm curious to know if they're asking any questions about, you know, if this works for my COPD, could it work for my CHF? So is it a pull that's coming from patients as well as the providers at your organizations?
Definitely, the majority of our patients have multiple comorbidities, including congestive heart failure, many diabetics as well. Yes, I think they see the value in a coordinated care model from hospital to home. They feel they're in a safe environment. They can have somebody to call. So they haven't specifically said for my diabetes, for my heart failure, but I think just in general, having kind of a coordinated model with somebody to reach out to, they feel so much safer.
Nice, thanks so much. I also think that, you know, of all the teams, we tried to focus somewhat on the return on investment, and that was why we wanted to do that value for money work with Risk Analytica. But I think it's so interesting that you took that approach to really understand those pre and post costs. And you talked about, you know, being in a period of like fiscal constraint. So I'm just curious, that level of looking into the cost effectiveness or cost savings data, was that something new that you had done in relation to this project, or is it something that you're accustomed to doing when you're looking at, you know, the possibility of rolling out new programs?
The program didn't exist prior to this. We needed to demonstrate to as many people as possible that we had positive results. So we knew that we needed to address the 30-day readmission rate, ED visits, length of stay, but we also we felt we needed to demonstrate as a team that we did cost avoid in a significant way. And again, depending who we were speaking to, we needed to demonstrate that we were being quite efficient with the resources that we did have.
Fantastic. I'd like if we could open up Graham Rocker's line. And Graham, obviously the cost avoidance piece was critical, I think, to the early buy-in, like garnering support for the Inspired COPD Outreach program in Halifax. I wonder if you could speak to that, but also looping back to our earlier conversation with Pierre Sorel in terms of their data.
Yeah, can you hear me?
We can.
So very interesting data from both sides. And thinking about the comments I made about the Quebec data and relating that to Ottawa, so there appears to be a spectacular drop in costs in Ottawa. But is it because there are only 13 patients contributing to those costs, whereas there were 46 patients contributing to those costs pre-enrollment? I think we need to be clear about that, because but again, the savings or aversion will still be spectacular, because even if you multiplied 13 times 4, which almost gets you to sort of close to 46, the savings would be really quite remarkable. But I think it just makes the point that we absolutely need to be clear about denominators in any kind of analysis that we're doing here. And in the Quebec case, I would be very keen to see that the 101 patients, for example, had all been in for exactly the same length of time, because I think the comparison of comparable time periods, it becomes relevant here, as opposed to, some patients have been in the program for 6 months, some patients have been in the program for 2 months, and that might make one heck of a difference in how one looks at it. But Jen's point about our cost aversion data, I think that what we did in the early stages to nail the Capital Health funding on a sort of permanent basis was to come up with, well, this is what these patients did in X months before they came into the program. That was only about 30 of them, and this is what's happened to them since they've been in the program for the same period of time, and the reduction was very, very striking, when one would have expected, like in Ottawa, they would have had a high 30-day type readmission rate. So I think it's just, I may be belly aching too much about this, but just looking for clarity on some of the comparison analysis.
Okay. Thanks, Graham. We do have a question from Lori Dunn. Are the corresponding community costs considered when looking at the value equation? And so, Wendy, that's going to be a question for you, but I'll just first say that Megan had shared in the chat box the link to the Risk Analytica report. That's available in English and French for everyone listening. And we actually didn't, in that case, look at the community costing data, and not because we didn't think that it cost anything, we do, but we knew that when it came to the big ticket costs, that when you look at sort of those length of stay and the hospitalizations, like that's where, through what these interventions entail, the self-management support and that structured warm handoff to community and working with community, that's critically important. But the keeping people out of hospital part is the part that is the really weighty part of that equation. That said, on our first part of this series, Corey Paul, who's the project lead from the Alberta Health Services Home and Community Care team, and they were the only team that really actioned Inspired fully in the community. They've done some really interesting work that particularly looked at cost savings from a community perspective. So I'd encourage you to take a look back at that first part of this two-part series. And Wendy's confirming here that they too only calculated the hospital costs. In my mind, I think where it would be great to take some of this cost data next is to really understand the per capita costs and of the full care continuum. I think we'll see the same play out, because we know that we're averting a great deal of the costs on the hospital-based side, but we'll have a better picture of what the value equation is. So, for example, that dollar spent on Inspired that we found can avert 21 in hospital-based costs, I'm sure that equation would narrow somewhat, although frankly I don't think a great deal based on the pre-post data. But we would see, I think, obviously a capture of the community costs. It's just that I think that those have been traditionally harder to capture. Okay, So unless Wendy or Graham, I'll just open up Graham and Wendy's line just in case you want to weigh in to that question in particular. So Graham maybe first and then Wendy.
Okay, so you have there's an absolute cost related to 46 patients, and there's a cost related to 13 patients in the two time periods. So one could very easily calculate the per patient cost, and for each of those time periods, right? And then we do the comparison.
Fair enough. Wendy, anything you wanted to add there?
So I just typed it in just to clarify. Of the 46 patients that sought hospital care pre-enrollment, for those same 46 patients, 6 months post-enrollment, only 13 had hospital encounters. So we are comparing the same patients.
Mm-hmm. Yeah, good point, and good point from Graham that what we'll do in future too is cue teams and folks to include the denominator, because I had that question for Wendy actually before we started and got that same clarification, and it's helpful, so then you understand you're working with the same cohort of patients. Okay, well thanks. So I'm going to move us actually to the final portion of our call today, and there's plenty of opportunity still for many people to be involved in what's really been a movement towards shifting care from hospital to home, focusing on care for people living with advanced COPD. So the work that you've heard over this two-part series is a snapshot of what the full cohort of 19 teams involved in the Inspired initiative are undertaking. And also CFHI does support work in shifting care from hospital to home. That's a big focus of the work that we do writ large. On our website, you can have access now, we referenced this at our last webinar, to all the resources that we shared and developed with teams, and this was made possible actually through gracious support of Boehringer Ingelheim Canada Limited. CFHI independently developed all of this material, but it was really thanks to their support that we were able to build the infrastructure to relay all of this information. So all of the resources that were part of the 12-month collaborative that Megan referenced earlier, as well as the analysis that's come from this, and we continue to work up analysis that comes from the Inspired Collaborative and the Inspired Collaborative teams, that will be freely accessible and available via the Inspired Hub, and we're really proud of that. There's also, for clinicians who are interested in implementing an inspired approach to care, there is actually the Inspired Change Package. So it really includes all of the details that one would need to be able to fully assess what are the interventions of Inspired, how could we customize this to local context, and would it work here? It includes some of the metrics that we recommend using. Finally, this is just a screenshot, quick screenshot of the resource hub I mentioned earlier, so feel free to check out online, and we encourage folks to use that. A screenshot of some of the upcoming webinars. So if you've liked what you've heard today, I think you'll like what's upcoming and queued up for our on-call series. And I think finally, I just want to be able to thank all of our speakers. So Wendy from the Ottawa Hospital, Jocelyn and Sonia from Monterey GS or Piedre Sorel, and of course Dr. Rocker, and my co-host Megan Rossiter, and our producers as well. Your feedback is really invaluable to us, so we'll hope you'll use the next minute or so to respond to these questions and tell us about that experience and how we could improve. So as you're filling that out, I'd also encourage you, if you'd like to learn more about other opportunities to join webinars and hear about what CFHI is doing and join those efforts, I'd encourage you to sign up for our CFHI newsletter and keep an eye on your email for upcoming listings of future webinars in the on-call series. Thanks everybody. That concludes today's webinar. Hope you have a great day, and thanks very much for joining us.
Ladies and gentlemen, this does conclude the conference call for today. You may now disconnect your line and have a great day.